speaker, Dr. Gerald Schultz. Please come over, sir. He will be speaking on radiation-associated cataracts among interventional physicians and support staff. Dr. Gerald Schultz. Ten minutes.
Okay, we're going to go on a different tack here because this affects our colleagues. It's not about endophthalmitis, although I found the papers great, and personally I use moxifloxacin. I did switch from vancomycin because of the hemorrhagic occlusive vascular disease that one of my patients did experience. But this is a different tack because this can affect our own colleagues. Okay, this is the outline. We're going to talk about the incidence of lens opacities in the cardiovascular lab, but it really affects any of the surgeons that use radiology, either in the operating suite or our radiologists in their routine work. We'll talk about the types of cataracts, the pathogenesis of the radiation-induced cataracts, and most important, prevention. As if anyone ever listens to us, but we'll try. I'll go through some definitions. GY is gray, so 60 mean gray is the highest risk category, and so far 5 is meant to be the low dose exposures. So if you have very low dose, it can build up in time, or inversely, if you have high doses, you get the effect much sooner. So a gray, and get used to these terms, it's a unit of the absorbed dose of ionizing radiation. In other words, there's 1 joule per kilogram of irradiation. That's what a gray is. And we talk about sieverts. Now, sieverts is really the quality of that radiation, how it will affect the body. And we have the equivalent dose, in other words, the quality that's absorbed in a tissue, and the effective dose is the sum of all the equivalent doses for a tissue effect over time. Well, at least you know what it's about. So who's at risk? I did mention the interventional cardiologists, the radiologists, and surgeons that bring the radiation into the operating room during their procedures. So let's go into the lens opacity incidence. And there are many variables depending upon the age of the individual, years of exposure, what their previous ocular history was. And these are the studies. For cardiologists, we find that they had a fairly high incidence, 43%, compared to some of the support personnel who, by the way, are usually much younger, and non-exposed, non-medical professionals about the same, which is very interesting, at least in this study. Support staff versus those who have nothing to do with medicine and never got any radiation, about the same. That's in this study. But it differs in this study where the radiologist had somewhat less, support people had more of a percentage. So it depends on which study you're looking at. They're still exposed. We can see that we have the non-users, by the way, those that don't even put their badges on. When they're checked finally, 50% of them did have opacities in their lenses, people who don't behave themselves. And here's another study, 20 to 30%. Again, it depends on the study that you're looking at. So where are the variables? I did mention the intensity, what the person's eyes were like before, the use of protection, biplane systems will go into that, position of the X-ray tube, and the amount of scatter radiation, and whether the radiation delivery system is under or above the operating table. We all know this. These are the classification, one of the classification of lens opacities, but the one that we're really interested in would be the posterior subcapsular, as it develops from very little to much further. And you'll see why we're looking at posterior subcapsular. Here's the Miriam-Fock grading system from very little, stage 1, to really opacification. And you can examine your radiologist friends, and you could want to give them various stages. But the radiation effect starts here anteriorly, and then it goes posterior. So when you look at them, it will be actually posterior subcapsular changes. It starts anterior, and then with the damage to the dividing cells that form a clear crystalline protein, it's really the posterior surface of the lens that's affected. So here, this is kind of stiff, but we have extracellular matrix that is involved, and we have the matrix metalloproteinases and the inhibitors of the matrix metalloproteinases. So it's all the interaction between these, whether we have more of the matrix metalloproteinases or the inhibitors of it, and that interferes with the regulation and expression of the molecules that could lead to aberrant communications and essentially development of an opacification. Because in a lens culture model, we can see that the differentiation of lens epithelial cells into fiber cells, it's altered by exposure. And if the fiber cells elongate and begin alignment with each other prematurely, you get opacification. Also, it causes misregulation of the gene function, so even the genes are affected. We did say that there's an occupational dose limit. We know what a sievert is, so this is what's recommended, no more. After that, forget it. Your career is over. So how do we prevent it? I did mention sealing suspended lead screens. Well, you'll see a picture of it. Leaded glass eyewear and positioning of the X-ray tube. And again, you want the radiation equipment be as far away from you as possible. So here, sealing suspended lead protection, the glasses. I did mention under couch or over couch. If it's under, that's protected. You get more protection. And the further away you stand, the better you are. But the best protection is robots. We get robots now doing everything. Let them be exposed. We have to have the X-ray equipment in best condition. They say that post-fluoroscopy is the best at minimizing fluoroscopy time and limit the number of images. Thank you very much for listening.
Thank you, sir, for highlighting professional occupational hazards which we are facing as medical professionals and how to take care of it. Thank you very much.